Hi, okay, I think we can start now. So good evening, everyone. I'm Dr. Kala Shanmugasundaram. I hope you all can hear me. Thank you for joining this month's CME program, which was organized by the Medical Education and the CPD Committee of the College of General Practitioners of Sri Lanka. This evening session was actually supposed to be moderated by Dr. Punyajit Balagampaya, but due to an unforeseen circumstance, he was unable to do so. So I will be moderating the session in his place. This evening's session is on the diabetic foot, role of a GP in the assessment and its management. And this will be delivered by Dr. Sabith Salieh. Dr. Sabith graduated in medicine at the Royal College of Surgeons in Ireland and went on to complete his medical internship in Singapore. His postgraduate medical qualifications are Master of Medicine in Family Medicine, obtained from the National University of Singapore, and international membership of the Royal College of General Practitioners, the MRCGP International. Dr. Sabith obtained his specialist registration as a family physician with the Singapore Medical Council and has over 16 years of clinical experience as a medical practitioner. He relocated to Singapore in March 2017 to contribute towards advancing primary healthcare in the country. His special interest is in diabetes, and he has successfully completed the certificate course in evidence-based diabetes management, which was conducted by the Primary Care Diabetic Group Sri Lanka in association with the Public Health Foundation India, and the certification course in diabetic foot management, conducted by Chellaram Diabetes Institute. At present, he is the director of the Diabetic Foot and Wound Care Center at CareTech Health Private Limited, which is a primary care clinic located in Colombo 3. He is the joint secretary of the Independent Medical Practitioners Association, IMPA. He is a council member of the Primary Care Diabetic Group Sri Lanka. He is an associate member of the College of General Practitioners of Sri Lanka and is currently the secretary of the Medical Education and Continuous Professional Development Committee of the College of General Practitioners of Sri Lanka. He also serves as a member on the Non-Communicable Disease, Public Relations, and Social Activities Committees of the College. He is a life member of the SLMA and the Sri Lanka Palliative Care Association. Dr. Salieh is an examiner for the MRCGP International South Asia Postgraduate Examination in Family Medicine. He has made several presentations on health and wellness to both the state ministries and the private sector companies as well. So without further ado, I would like to invite Dr. Salieh to start his presentation. And can I please remind everyone to stay muted? Thank you. Over to you, Dr. Salieh.
Thank you, Kala, for the kind introduction. I would like to thank the president of the college, Dr. Pushpa Veerasinghe, and the college as well for inviting me to conduct this webinar. A very good evening to you all. We've got hopefully it'll be an interesting and a fruitful session for you. We've got quite a range of topics to cover. I'll try to keep, I'll do my best to keep to time. And so I'll cover certain things, spend a bit more time, which I feel that is relevant in primary care. Sorry, is the presentation?
Yeah, it's on. We can see it.
No, I'm just trying to switch to the slide. Sorry. Sorry. Earlier it was switching on to the second.
Just click twice. Just click twice, then it will work.
Is it?
It should work because when you click the Zoom controllers, it will switch from presentation to the Zoom controller. Yeah.
Oh, is it? Hold on. Let me. Sorry, it's unusual. Exit to full screen mode. Hold on. On my screen. And it's not moving. It seems to be stuck. Hold on. Oh dear. Okay. Can you see it now? All right.
Yeah, we can see it.
All right. Okay. So sorry about the glitch. Okay. I mean, this is the overview and the outline of my talk, and we'll try to get through it as quick as possible. And then we'll be happy to take some questions at the end. All right. So when you talk about why diabetic foot is important, right? I think most of us know 1 in 5 adults in Sri Lanka has either diabetes or pre-diabetes. 85% of the diabetic related amputations are due to foot ulcers, which is generally preventable, and this accounts for more than 50% of non-traumatic lower limb amputations in the world. And someone loses a leg every 20 seconds in the world due to complications of diabetes, right? And the risk of a non-traumatic lower limb amputations is 15 times more commoner in a diabetic when you compare the stats with a non-diabetic, right? And it's truly a debilitating complication of diabetes, and a significant burden in terms of the cost to a country's healthcare system, right? So this is a slightly older study that looked at the prevalence of neuropathic foot ulceration in Sri Lankan diabetic patients at the NHSL, the National Hospital, and that showed about 33% of all non-insulin dependent diabetic patients were at risk of developing an ulcer, right? And over 10% either had a foot ulcer, an active ulcer, or a history of foot ulcers, or a lower limb amputation. So as you can see, it's extremely important. So back to basics before we progress. So you can see your foot, basically anything distal to the metatarsals is referred to as your forefoot. Your midfoot consists of your cuneiform bones, navicular bone, as well as your cuboid, and the talus and calcaneus form part of your hindfoot, right? When you talk about the layers of the skin, we've got 3 main layers: your epidermis, dermis, and the hypodermis. The epidermis and the hypodermis. So when we refer to as superficial, it basically means penetrating up to the dermis. And if anything penetrates even deeper, involving the hypodermis or your subcutaneous structures, then we consider it deep. All right. So what is the definition of a diabetic foot in a person who has diabetes and has one or more of the following: peripheral neuropathy, peripheral arterial disease, infection, ulcers, neuroosteoarthropathy, gangrene, as well as or an amputation, right? What are the risk factors? Of course, if you have diabetes for a longer period of time, you're at a risk of developing it. Poor sugar control, foot deformities, presence of microvascular or macrovascular complications associated with diabetes. Smoking is a risk factor. Previous foot ulcer and amputation. That if you have any of that, automatically you become high risk. And of course, poor socioeconomic conditions. We do see in developing or underdeveloped countries, especially countries like in Africa, where the incidence is much, much more. Right? So why does diabetes or why does high sugar cause damage to the nerves, right? So you know that there are small vessels that supply nutrients and oxygen to the nerves. These are referred to as your vasa nervorum. And diabetes is an inflammatory process. There's a lot of oxidatory stress, and there's occlusion to these vessels. And as a result, the nerve fibers, whether it is myelinated or unmyelinated, get damaged, right? And the next slide, you would see the degeneration occurs in a distal to proximal direction, right? And that is why they start with peripheral symptoms on either the toes or the hands, and then it progresses proximally. All right. So when you talk about diabetic peripheral neuropathy, it affects you. You know, you have an autonomic neuropathic component, a sensory neuropathic component, as well as a motor neuropathic component. Now, when you talk about diabetic peripheral neuropathy, we know that there are 2 types. You have your generalized symmetrical polyneuropathy, as well as the focal or multifocal polyneuropathies, which is generally asymmetric. But the commonest form of diabetic peripheral neuropathy is basically a chronic sensory motor neuropathy, right? So when the autonomic, the implications of having an autonomic neuropathy is basically you have a decreased sweating in the foot, right? And as a result, the foot becomes very dry. You have fissuring, and as a result, you lose the function of the skin being a protective barrier, right? And you have you have some microvascular dysfunction or AV shunting as well. That's why you'd see people with chronic autonomic neuropathy, when you look at their feet, there'll be a lot of distended veins, right? The sensory neuropathy component, so they would always complain of numbness, reduced sensation. A lot of them would tell you, it's like you're walking on cotton wool, right? And as a result, your sensation, because there's reduced sensation. You can develop callosities, ulcers, and you won't realize these and until they become infected, right? And then a lot of them, they complain of pins and needles, burning sensation, tingling, and some people are very, very sensitive, or what we call hyperesthesia. And usually most diabetic neuropathies tend to get worse at night, right? And a lot of them also, we know that it affects your proprioception. They have a loss of coordination, high risk of falling, and also contributes to deformities of your feet, right? The motor neuropathy component causes weakness and muscle wasting, right? So as a result of, there is an imbalance in the structural anatomy of your foot, and as a result, you'd end up having toe deformities as well as foot deformities, and sometimes they complain of muscle twitching and cramps, right? Okay, so remember, those were the microvascular complications, and we know neuropathy is a microvascular complication of diabetes. You can also get a macrovascular complication, which is basically peripheral arterial disease. So what are the symptoms? People, they present with cramps, sometimes intermittent claudication in their calves or thighs, numbness. They may get wounds that don't heal for a long time. Color changes to the skin, hair loss as well is a sign that we do see, shiny skin appearances, and changes to the nails. But you have to remember, when someone has significant peripheral neuropathy, even the intermittent claudication symptoms sometimes could be masked. So that's something we need to always keep in mind, right? So this slide basically summarizes that, when you have diabetes, a lot of it can affect, and what we are trying to prevent is a diabetic foot ulcer, right? Because once you get a diabetic foot ulcer, healing it is very difficult, and also you are at a risk of amputations and subsequent ulcers, right? So it significantly affects your quality of life and your morbidity as well, right? So that's the cornerstone basically of management in terms of diabetic foots, right? So what is this? We do see sometimes you may see patients with coming into your clinic with very, very dry skin, right? And this is due to the autonomic neuropathy, and especially you can see the fissuring over here, right? So when you see this, you make sure that you have to advise them to use a moisturizer cream, and there are many moisturizers. Some are specific for diabetics and specific to the feet, right? And contain arginine that supposedly would improve blood flow. So you need to ask them to use the moisturizer at least twice a day, if not even once a day, and apply it on the sole and on the top of on the dorsum of the foot, but avoid the web spaces. And when they are having very severe dry feet, we must always advise them to avoid walking bare feet, right? What is this? So sometimes you see this. These are basically corns, right? You could get multiple corns in the plantar aspect of the feet, on the toes, right? And this can happen even in non-diabetics. But what I wanted to highlight here is, when you are a diabetic, you must advise your patients not to use any medicated corn plasters, right? Because that can cause maceration of the surrounding skin, and damage to the surrounding skin, and potentially result in an ulcer, right? So no medicated corn plasters or home remedies when you have these corns. So you need to come in, and then what we normally do is a corn treatment, where we remove the corn, right? And these can happen in different parts of your feet. This is a wart, right? So we need to be a bit mindful. So normally we don't do any wart treatment at the clinic. We send them to a surgeon or a dermatologist, because warts tend to have deeper roots, right? But we have to remember all these different things that can occur in a non-diabetic can occur in a diabetic patients, but we need to be a bit more cautious, right? Okay, so this picture basically highlights callosity, right? If you look at it, you can have multiple callosities, right? And some people, it looks a very benign lesion, right? And a lot of us tend to neglect it. But what I wanted to highlight here is, if you see a callosity in your clinic, right? You need to actively manage it. Don't ignore it, right? And I'll come to the reason why we shouldn't ignore it in a short while. All right. So this slide is basically to highlight, when you have diabetes, or even before you develop diabetes, you could develop deformities, right? Some of us tend to have arch issues, right? Either a high arch or flat feet, right? And if you look at the normal arch, this is the classical normal weight bearing the footprint. But when you have a high arch, there are certain more pronounced pressure in these two areas, right? And when you have flat feet as well, the pressure tends to be a bit more pronounced on your medial aspect of the inner part of your foot, right? And then some people have metatarsophalangeal deformities like your bunion, salus valgus, all of these things. So what we have to remember is even before developing diabetes, some of our patients may have these deformities that increase their risk of problems with their feet. This slide is to show us that if you have diabetes for a long time and you have motor neuropathy, that can also change or alter the structure of your feet, right? Because there's a lot of imbalance between the muscles, wasting of the interossei and lumbrical muscles, which cause deformities. And again, if you look at the normal plantar weight-bearing pattern, and if you compare it to somebody who has significant motor neuropathy, you would see that these areas have higher pressures, and therefore they are predisposed to callus formation and subsequent ulceration, right? What is this? Does anyone like to comment on the image on your left or to my left and the image in the middle? Okay, so in the interest of time, what we'll do, so this is basically a claw toe, right? And this is a hammer toe, right? And this is an overriding toe. So sometimes we do see these patients with these deformities. So just how do you differentiate both of them is at the DIPJ, right? If at your DIPJ, if it is flexed, then we refer to it as a claw toe here, right? And if it is extended, it's called a hammer toe. Now, why is this significant when you have diabetes? Is because when you have the claw toe, I'm hoping you can see my cursor, no? Yeah. When you have a claw toe, at the base of this claw toe, that area predisposes to developing a callus, right? And a high risk for ulceration. Similarly, when you have claw or hammer toes, on the top of the roof of your foot, the shoe, can keep hitting this area, and then you can develop, because of the friction, you can develop a callosity, right? So that is what we need to understand. So why is a callosity so important, right? Is because when you have a callus formation, you can have a subcutaneous hemorrhage underneath, and that can become infected, right? And then you have an ulcer formation. So when you see a callosity, you know that if you neglect that, you are definitely going to have an ulcer right thereafter. So we need to, and why does this happen? Because of repetitive mechanical forces, imbalances in your feet. Some people, because they wear ill-fitting footwear, and also always remember foreign bodies. So in our clinic, we do see a lot of patients coming in with a callus, and then when we do the treatment, we find small stones, small wood splinters. In fact, we've even found glass, right? So all these things can happen, right? And then subsequently that can get infected, right? So we tell them you use the cream properly, and we do a shaving of the callosity. And it's not only when you talk about callosity treatment, don't just treat it acutely. You have to think about sorting out, because if they will come back to you in 3 months or 6 months, if you don't actually look at their footwear, right? Look at their footwear. If there is any deformities in the toes or in the calluses, then we may do a 3D foot scan if you have the resources, and get customized insoles or footwear for them, because otherwise they're going to be repeated. They're going to be coming back to your clinic in 6 to 12 months, right? Okay, so we're just going to do a pause for a moment in terms of a case scenario. A 62-year-old lady with a history of diabetes type 2 for the past 15 years, complicated by nephropathy, retinopathy, and peripheral neuropathy, comes to see you, right? She complains of an acute left foot swelling associated with redness and increased warmth for a period of 5 days. There is no fever, no pain, and no history of trauma or wounds. What are your differential diagnoses? I'm trying to make it an interactive session, so please, anyone, unmute yourself and share. We'll maybe spend a minute or two on this. What are the differential diagnoses that's going through your mind? Okay, so acute cellulitis, yes, that's an important differential. What else?
Deep vein thrombosis, DVT.
Absolutely, you have to always think of someone presenting with an acute swelling, DVT. Yes, what else?
It could also be an acute trauma, a fall, fracture.
There is no fall though, no history of trauma. But what you were worried about is like a fracture, no? Okay, right. Anything else? So how would you investigate this person? Is there anything that you would do? CRP, okay. Full blood count, all right. So looking for infection, yes. So I think most of us were thinking down, okay, cellulitis, DVT. So how would you manage them?
Look for an entry site. If it is cellulitis, there can be entry site like underneath, like
yes, of course. So you have to do a proper examination of the foot. I see someone mentioned the ankle ABPI, ankle brachial pressure index. Okay, and sometimes, okay, if we suspect cellulitis, we would cover them with antibiotics, isn't it? Right. So I'm going to pause there and I'm going to come back, right? We'll come back to what is the actual diagnosis, right? So Charcot neuroarthropathy, right? Or what we commonly refer to as CNO. What is Charcot? Charcot's foot, basically, it's a relatively painless, progressive and degenerative arthropathy of a single or multiple joint caused by underlying neurological defects, right? So it can affect your foot, ankle. The prevalence is about 0.8 to 13%. It's found both in type 1 as well as type 2 diabetes, right? Usually it is unilateral, but sometimes can be bilateral as well, right? In 25% of the cases. And what we have to remember is Charcot's foot, on average develops after many years of diabetes. So typically maybe 10, 12 years of diabetes, right? And the pathophysiology, basically it's a combination due to sensory motor neuropathy, autonomic neuropathy. Your joint becomes unstable, and then you have trauma, and then you have some form of osteoarthropathy, subluxation, spontaneous dislocation, and neuropathic, or what we call microfractures, right? So the answer, actually, the diagnosis in that patient was an acute Charcot's foot, right? And this was one of the take-home messages that I want all of you all to keep in mind, because always consider it in a diabetic patient with neuropathy presenting with foot swelling, increased temperature. You may or may not have redness, but the clue is in the absence of any skin wound, right? Pain, again, could be minimal or absent, right? So you're absolutely right. We need to make sure it's not cellulitis. We need to make sure it's not a DVT, but this should be at the back of your diagnosis, because if it is not, often the management we give the patient is completely wrong, because for acute Charcot, the management is very much different, right? So we'll come to that in a minute. What are the risk factors? Previous foot ulcers, retinopathy, nephropathy, end-stage kidney failure, and of course, some non-diabetic conditions like rheumatoid, iron deficiency, anemia, and obesity, right? And often we check for increased temperature. Sometimes we use the palm of our hand or infrared thermometer, right? So how do we investigate an acute Charcot's, right? Bloods, well, basically FBCs, ESR. So the guidelines, the International Working Group on Diabetic Foot, the guidelines, they suggest they do not to use bloods to diagnose or exclude Charcot's, right? So it's a clinical suspicion, but we do X-rays sometimes, right? Now, when an X-ray is done, remember, if the X-ray is normal, it does not rule out Charcot's, because even radiologists sometimes can miss this, right? So if you do suspect it, when you're ordering an X-ray, if it's the ankle, you order a bilateral ankle X-ray. If it's a foot, bilateral, so that the radiologist can compare. And the usual view is AP mortis. What do I mean by mortis view? Basically, the foot is internally rotated by about 15 to 20 degrees and mildly dorsiflex, right? And ideally, these should be weight bearing, because if it is non-weight bearing, you may not catch the malalignment, right? And always get it reported by a radiologist. And again, I would like to reinforce, just because you get a normal X-ray, it doesn't mean this is not acute Charcot's, right? The investigation of choice is, of course, an MRI scan, but sometimes we may not have the resources to be able to do it. So then sometimes if that is contraindicated, they do a CT scan as well. But you have to always suspect it. So now this is a X-ray when you compare, and that's the reason why we say do bilateral. It's easy to compare. So you can see there's an increase in soft tissues, right, around the tarsometatarsal joint, and some irregularities that we see here, right, compared to the picture on A, right, where it's much more thinner, the soft tissue. And if you look at this, you can see here there are small avulsion fractures here, right? small avulsion fractures, and later on, subsequent medial dislocation of the navicular, right? Again, sometimes a lot of these X-ray changes are missed, right? And here, this is an MRI of the midfoot, and you can see the white lines show us that there's a lot of marrow edema, right? That is inconsistent with acute CNO, right? And that's what we mean. So how do we manage acute Charcot? So when you talk about the management, the key thing is immobilizing and offloading, because what we would have done in that patient is we would have covered them with antibiotics and told them, yes, elevate your leg, but we would have never offloaded it. And then what happens, that person keeps walking, and that makes it worse, right? So immobilization and offloading is important, very important. And the immobilization should be knee high. Make sure you've done a proper vascular assessment in terms of checking the pulses before putting them in a total contact cast, which is the first line. And now sometimes we have these knee high walkers as well that can be used. What is important is what is important is to understand that it has to be knee high, not up to the ankle, right? And you need to refer to an orthopedic surgeon, a foot ankle specialist, right? The use of alendronate, pamidronate, pamidronate, or zolindronate has not been shown to be, there's no evidence for advocating the use of these. With regard to calcium and vitamin D replacements, what we normally suggest is, if they or deficiency, then treating them is fine. With regard to surgery, generally not done in acute CNO, right? So that's something we need to remember. Generally, surgery is not done. Unless, of course, it's very, very rarely, where there's certain special indications for surgery, like if they have, if they are at a high risk of developing an ulcer in the offloading device itself, or if there's severe joint instability, right? So this is a total non-contact cast here, and this is the knee up to knee high walkers, right? Okay, so what happens is what happens if you don't properly manage an acute Charcot? With months, sometimes they will develop all these foot deformities, right? As you can see over here, right? And you can see this rocker bottom foot, right? And you can see the X-ray changes that has happened here, often involving the midfoot, right? And once they develop this rocker bottom foot, right, they are at a high risk of ulceration and high risk of amputation, right? So this is what we always are trying our best to prevent, is them getting to this stage. And if you actually intervene correctly and catch an active Charcots, an acute Charcots, and by immobilizing them, you can prevent, right? But if you do see those patients even coming in with Charcots in remission or chronic Charcots, we can advise them to get the proper footwear, which is very important, right? So where they have a different, depending on which part of the joint you want to take the pressure off, they see a technician and they get a proper footwear, customized one made for them, right? Okay, cellulitis, right? So this is something that is that we do see often, right? A skin infection, and so we need to treat them with appropriate oral antibiotics, and sometimes they may need even intravenous antibiotics, right? Ingrown toenail, very important, because you see, when we always we must advise diabetics to cut the nail straight. Don't cut it in a curved way, right? And when you see this, and this is very important, even to catch an ingrown toenail before it becomes infected, right? And need to refer them for appropriate treatment. And if they are infected, we cover them with oral antibiotics, and then once it settles down, we do a partial nail avulsion, right? This is extremely important because all these things, it can start from a small wound like this and result in an amputation, right? Fungal infections are very, very common. We do see a lot of fungal infections in diabetic patients. They are more prone to fungal infections. It can involve the nail, the web space, the foot as well, right? And as GPs, it is important for us to be able to manage these infections very carefully and competently, because if not, you can get a secondary bacterial infection on top of these things. And if it's a severe fungal infection, again, high risk of amputation, right? So these are fungal toenail infection classifications, and the nail basically becomes very dry, very thick, and then you'd have it lifting off the nail bed, right? Okay, so how do we manage fungal infections, right? So we know that I mean, a lot of us are familiar with the use of topical antifungals. They come in various forms: creams, lotion, tincture, powder. I think most of us use either an allylamine or an azole, right? So allylamines are terbinafine, azoles are clotrimazole, miconazole, ketoconazole, and iconazole. These are mainly imidazoles. You have fluconazole and itraconazole, which are triazoles. Nystatin is not used mainly because they're not very effective against dermatophyte infection. And then sometimes we may need to use oral antifungals as well for severe infection, right? So I'm just giving you a treatment example, and this is something that I use, but you can, I mean, there are different people they have their own prescribing preferences. So for a web space infection, sometimes you can use something like miconazole, 2%. And what we need to tell them is you need to wash that area, dry that area. Now, when you're drying that area with a particular type of cloth, don't use that same cloth elsewhere, otherwise it will spread, right? And then apply a thin layer, use a cotton bud, don't use your finger, twice a day over the affected areas. And you need to allow them, so sometimes it can take up to 4 to 6 weeks for the entire infection to settle. And I always tell them, apply it, and after it's completely gone off, continue to apply it for about a week more, because otherwise sometimes to the naked eye you can't see these things and it can come back again. Onychomycosis or toenail infections, generally terbinafine, literature favors terbinafine over azoles, right? So we use the 1% lotion, and again same thing, apply a thin layer using a cotton bud maybe twice a day over the affected nail. But you have to understand onychomycosis of the toenails tends to take longer, so you may need to apply for at least even 3 to 6 months, and sometimes some patients we also apply almost for a year, right? And if it's very, very advanced, we can also give them oral antifungals, right? So you can use itraconazole, which is 200 once a day after a full meal for about 3 months, right? But you need to remember, you need to do a baseline liver function test and monitor the liver function test when you're on long-term itraconazole. And if you're dealing with a female patient in a childbearing age, you need to advise them about contraception, because they cannot get pregnant while on antifungal treatment, right? And some people use oral fluconazole, which is a once a week dose, right? Some people for the pulse treatment, I mean, some people do use pulse treatment, but I find that in my experience, for toenails, a daily treatment for 3 months is a bit better. All right, foot blisters. So the reason why I wanted to bring this up is we do see a lot of patients coming in with a blister, and they tend to do a lot of home remedies, right? Take a safety pin or a scissor, and then they try to de-roof it themselves, right? So what you need to advise your patients is don't go to do any home remedies. They should consult their doctor, and then we do under aseptic conditions, we do either a de-roofing using a needle or a blade, right? And put them on a dressing. Okay, so diabetic foot ulcers, right? So let's talk a little bit about ulcers. What are the risk factors? Of course, neuropathy, peripheral vascular disease, foot deformities, and microvascular complications associated with diabetes, obesity, and patient factors. What do I mean by patient factors? So, for example, if you have poor socio-economic status, right? So they walk barefoot, they don't use the proper footwear, they don't know how to cut the nails properly, and they do all these home remedies for certain traditional medicine remedies. All of that increases their risk of developing an ulcer, right? So we know that when you talk about diabetic foot ulcers, neuropathic ischemic ulcers and neuroischemic ulcers. In Asia, neuropathic ulcers contribute to most of the ulcers, right? In the West, because peripheral arterial disease is more common, you tend to have the ischemic ulcers maybe equally in terms of incidence. But when you talk about neuropathic ulcers, it mainly affects the plantar aspects, right? Your pressure points, right? And ischemic ulcers, on the other hand, are on the toes. You can have it on the dorsum of the toes or side of the foot, right? So that's important to keep in mind, all right? Now, classification of foot ulcers, right? I don't want to get into too much of this because I'm just going to share with you because there are many classification systems, right? I think the Wagner system was used for a long time. I think it was first developed in 1976, then subsequently modified in 79. Previously, it was the most widely used system, but the limitation with that is it does not consider clinical parameters like your peripheral arterial disease, neuropathy, does not differentiate between infection and ischemic lesions, right? So the IWGDF recommendation is that they use the SINBAD system in terms of classification. So what is the SINBAD system? Basically, it looks at a few things. Your site of the ulcer, the ischemia, neuropathy, bacterial infection, is it there? What is the area and what is the depth? And then you have a score. So you score the ulcer, and there was a study I think 2 years ago in India which validated the SINBAD system. So they found if you have a lower score, that means it's a higher chance that you can actually the ulcer will heal. So anything with a score of 2 or 0 has a favorable prognosis, but a score of 3 or more resulted in some form of amputation, right? So that's important. So this is the University of Texas staging system. I know a lot of us, we do use this as well. It's basically a 4x4 matrix that assesses ulcer depth in the horizontal component and infection and ischemia in the vertical component, right? Okay, so what we want to basically highlight is, so you can see here, this is dry gangrene, right? And sometimes you get this neuroischemic, which is wet gangrene, and this is a plantar ulcer, right? So the whole purpose of this is trying to see how we can prevent this, because that is truly an important aspect. We don't want our patients to develop these end-stage complications, right? So when you talk about management of diabetic foot ulcers, this is a true example of prevention is better than cure, right? And that's where, as GPs, we play a crucial role, because we are the first primary point of contact for most patients, right? So what our role is to identify high-risk patients of developing an ulcer and educate all our diabetic patients regarding proper foot care as well as footwear advice, right? And then, of course, once you develop an ulcer, we manage it in terms of debridement, offloading, extremely important for neuropathic ulcers, glycemic control, infection control, and surgical intervention. All right. So this, you see, once you have some form of amputation, your foot dynamics are completely changed, and you automatically are at extremely high risk of developing future ulcers and wounds. So it really affects your morbidity. It affects your quality of life and reduces your lifespan, right? That is something studies have shown over and over again, right? So it is crucial that we do whatever we can to prevent amputations, and it can be done, right? So how do we do it? How do we go about doing it? One of the main things is doing a diabetic foot screening. And we do see, I've seen so many patients come into the clinic and they tell us, okay, doctor, I've been a diabetic for 10 years, 15 years. And when I've asked them, have you ever got your diabetic foot screening done? They have no idea what it is, right? They say, doctor, I've checked my eyes, I've checked my kidneys, right? So this is something that is, there's a lot of room for us to kind of improve on, right? So who should do it? Based on local as well as international guidelines, all diabetic patients should have a diabetic foot screening. When should you do it? If you're type 2 diabetics, at the time of diagnosis, right? If you're type 1 diabetic, you can do it 5 years after your diagnosis. How often should you repeat it? Well, basically, there's a high risk stratification, which I will share with you in a minute. Okay, so how do we, and this is something which is very important that I want to share with all of us, because all of us, no matter, we are all GPs, we practice in our clinic. It can be very busy clinics at times, but what we can really do is take a bit of time and learn how to inspect and do even a basic diabetic foot screening, right? So when you talk about foot examination, inspection is absolutely crucial. Look at the skin. Is the skin dry? Are there any corns, callosities, fissures, ulcers? Are there any changes of PVD? So loss of hair, skin atrophy. Is there any signs of infection? Is there any swelling, redness, distended veins? Remember, we were talking about motor neuropathy. How's the temperature? Is it warm? Is there any fungal infection in between the web spaces or elsewhere? look at your muscles, right? Are there any deformities of the feet, right? Look at the nails. Is it thick? Is there discoloration? Are the nails ingrown? Is there any issue? Are there any infection? And very important is to look at the footwear. Sometimes the footwear, the soles of the patient's footwear can tell you more than the patient themselves, right? So inspect their current footwear, right? How is it fitting? Is it tight for them? Is it too loose for them? Is there any back support? What is the material? Is it very heavy? So, and I will come to the footwear in a bit as well. In terms of diabetic, there are special footwear for diabetic patients, but this is very, very important, right? Now, the next component is doing a neuropathy assessment, right? So we know, and this is something that you can do in your clinic as well. So we can do the ankle reflex, right? And then we use a monofilament, 10 gram Sims-Weinstein monofilament assessment. So the monofilament assessment, the main reason we do that is to identify where an ulcer can occur on the sole of the feet, right? And I'll come to that in a minute. A tuning fork. So vibration is extremely crucial. When you use a tuning fork, remember it's a 128 hertz tuning fork, right? And we use the tuning fork. Always remember to use a reference point, right? So I usually use the sternum, a reference point, and then on the big toe we use the proximal interphalangeal joint first and check and see whether they feel the vibration there, right? And you can and if they feel the if they don't feel the vibration, then you can move from a distal to a proximal manner involved. Then you can check the metatarsophalangeal joint of the big toe and then the ankle joint, medial malleolus, if they don't feel the distal areas, right? Proprioception, we know that a lot of them have issues with proprioception and as a result can fall. So we check the proprioception again. We use the big toe, right, at the interphalangeal, the proximal interphalangeal joint. And then we ask the patient to close the eyes and say, first you tell them, look, this is up, this is down. Then you ask them to change, you ask them to close their eyes and ask them, okay, is this up or down? And we do it maybe 3 times for each big toe, right? And these are basic things that you can do in the clinic, right? Some, if you have access or the resources, some of us, we use a biothysometer or a neurothysometer. Basically, we check the vibration perception threshold. So what it is you use the probe on the pulp of the big toe and you have this mechanical vibration, this device. So you start from 0 volts and you tell the patient, okay, look, let me know when you feel it, right? And then they feel it. Again, you use a reference point before starting it. Usually the VPT should be less than 25 volts, right? If it is more than 25 volts, it's indicative of neuropathy, right? Okay, so how do you do a proper monofilament test? So when you do a monofilament test, so first thing is before using the monofilament, we have to remember sometimes it can be very stiff. So we need to bend it a few times, right? Or if you're using a monofilament after a long time, you need to just use it a few times, bend it, then it will reduce the stiffness. Otherwise, if it's stiff, it delivers a force of more than 10 grams, right? So you can see in this picture, these are the points that we normally check. So there are different people. Now, if it's a very busy clinic, you may do a 4-point assessment. I generally do a 6-point assessment, right, on these 2 areas here and here. So you keep it at 90 degrees to where you're assessing. Then you need to apply pressure until it buckles, right? And this is what we mean by buckling of the monofilament. And then you release. Now, you do this first at a reference point at the sternum, and you tell the patient, close your eyes, right? And then when you apply, you must tell the patient, say yes when you feel the monofilament, and then they will say yes, right? And that is how you do a proper monofilament assessment. And you need to remember, avoid calluses, right? If there is a callosity, don't go to do the monofilament testing there. The patient won't feel it, right? And usually we do it twice, and if the patient cannot feel it twice, then we may mark that area as negative. Now, even if you can't get hold of a monofilament, you can do it even with a toothpick or even the back of your patella hammer, right? So you can try it. In fact, in Africa and all the guidelines, if you're really completely without it with your fingers, they do it. That may not be a proper assessment, but at least the gist of it is basically use something to assess that area, right? That is extremely important, right? Diabetic foot screening, peripheral vascular assessment. So distal pulses, just check your distal pulses, right? And if you have, so the dorsalis pedis, posterior tibial. If you have one good pulse, that is good enough, right? Some of us check the ankle brachial pressure index, right? The ABPI. So how do we do that? Basically, we get the patient to rest in a supine position for about 10 minutes. Then we check the systolic pressure in the right arm, right leg, left leg, as well as the left arm using an ultrasound Doppler probe, right? Now, I've given an example here to how we measure the right ankle brachial pressure index. So the right ABPI, we take the highest systolic pressure on the right foot. So for example, you measure the systolic pressure on the right dorsalis pedis, right posterior tibial, take the higher reading, right? Then you divide that by the highest brachial pressure reading in both arms, and your ABPI value, usually it should be from 0.9 to 1.4, all right? If it is less than 0.9, then you tend to have a lot of less than 0.9, it's indicative of peripheral arterial disease, right? If it is some diabetic patients, especially if they're very, very elderly, they can have a ABPI value greater than 1.4, right? If they have calcified vessels and things like that, right? So normally when we see a person with peripheral vascular disease, if they are asymptomatic or if they have very calcified vessels, we start them on atorvastatin 40 milligrams because this has shown to improve, their condition. If they are symptomatic, then we start them on aspirin along with a statin and refer them to a vascular specialist for further assessments like an ultrasound Doppler, right? Okay, so why is patient education regarding foot care and footwear important, right? Now, this study was done by Vimalaratne et al. Looking at I think it was at Kalubovila Hospital, looking at about 300 odd patients attending the diabetic clinic, right? And they found actually 17.8% of them did not inspect their foot daily. 20.2% did not wash their feet daily. 44.9% had poor foot hygiene, right? And 89.2% did not wipe the web spaces of their fingers, right? And 93.5% did not apply any moisturizer, right? And the shocking thing was 83.9% were walking bare feet, right? And in fact, about 26.9% of them were keeping heat pads and hot water bottles, right? So you can see there was a huge, there are a lot of improvements in terms of knowledge, in terms of foot care and footwear knowledge, right? And 70% were wearing unsuitable footwear, and 79.3% did not inspect their footwear before wearing, right? So this is a very important slide in terms of how we should educate our patients to look after their feet, especially when they have diabetes, right? So the first thing is we tell them to wash their feet daily with lukewarm water and soap. Don't use hot water or hot oils or anything like that. They must dry the feet. Use a proper, not a rough cloth, but a proper cloth to dry the feet, and especially the web spaces, right? Apply moisturizing lotion, very important. And when you apply it, remember, you apply it on the soles, you apply it on the top part of your feet, but avoid the web spaces, right? Then you must check your feet daily, right? So you can use a mirror to have a look and see, right? To check and see, okay, look, is there any wounds? Is there any blisters, any redness, right? If you can't check it with a mirror by yourself, you can get somebody else to do check it for you, right? Trim your nails, remember, straight across. Don't trim it in a curved way, straight across, and don't cut it too short, right? Change your socks daily, every day. Never walk barefoot. I think this is something very, very important. We have to tell your patients, even inside your house, don't walk barefoot, right? And examine your shoes daily for any foreign body. So sometimes you can have a stone, you can have insects, all these things. And so always it's good to dust your footwear and examine it before you wear it, right? Avoid medicated corn plasters. If you're a diabetic, do not apply any hot oils. Do not soak your feet in hot water or ice water, right? That is also another common thing because of the neuropathy. They try to use extreme temperatures. Do not sit cross-legged for a long time. Avoid home treatments of corns and calluses and blisters as well, using a knife or blade. The only thing we tell them, okay, you can use a pumice stone if you like to get rid of the dead skin, right?
And very important, avoid ill-fitting footwear. When they are buying footwear, tell them always to buy it in the end of the afternoon or evenings, because generally the foot is more swollen. If they go in the mornings, they will bite, and and then when the foot swells, the footwear becomes tight, right? So coming back to my initial thing about, okay, how often should we screen it? Remember, so this is basically the IWGDF 2023 guidelines. And we need to remember that screening frequency is based on expert opinion, right? There's no published evidence to support these intervals. So if say, for example, we risk categorize them into, and when we talk about the risk, we're talking about the ulcer risk, right? So very low, moderate, and high. So if you are very low, what that means is you don't have any loss of protective sensation or signs of peripheral arterial disease. Then we can screen them once a year, right? If you are low, that is, if you have some form of neuropathy or peripheral arterial disease, we generally bring them back in about 9 months. If you have moderate amount, that is loss of protective sensation and peripheral arterial disease, or if you have a neuropathy plus a foot deformity or PAD with a foot deformity, then we bring them back a little sooner, maybe 6 months. If you're at high risk, that is, if you have a neuropathy or peripheral arterial disease with one or more of the following: a history of foot ulcer, a previous amputation, or end-stage kidney disease, then we see them a bit more closer, 3 monthly. But like I said, these are based on expert guidelines, and you can make a call as to how the gist of it is basically to keep a close eye on them, because the higher the risk of ulceration, right? Okay, so wound care, we'll talk a little bit about wound care. So remember, generally neuroischemic ulcers and ischemic ulcers, we try not to manage it in outpatient setting. Neuroischemic ulcers, we refer to a surgeon for debridement and amputation. Ischemic ulcers, we don't do any debridement prior to revascularization, right? Unless, of course, it's a life-threatening or a limb-threatening infection, then we debride and subsequently revascularize. So what do I mean by debridement? Removal of non-viable and devitalized tissue from the wound bed to promote granulation, tissue formation, and re-epithelialization, right? Which basically encourages wound healing, right? So this is important, right? Non-surgical debridement. So, the gold standard is we talk about sharp debridement. Sharp debridement is the debridement that we do in an outpatient setting, right? Surgical debridement is what we do in hospital, in a theater, right? So the consensus is basically sharp debridement with a suitable dressing is what is recommended, right? So again, enzymatic debridements, autolytic debridements, all we use as part of our thing, but not the standard of care is still sharp debridement, right? So there are different types of dressing basically to highlight, but what I wanted to highlight here when you talk about wound care and there are a few factors we need to consider. The dressing, in terms of the dressing type, when we're choosing a dressing type, it needs to maintain the correct moisture. If the wound is too dry, it doesn't heal. If it's too moist, it doesn't heal. So that maintaining the correct moisture is very important. Wound protection, right? In terms of infection, reducing the infection risk, and of course, infection management and odor control, especially in the larger wounds. What I wanted to highlight in this slide is there are different types of dressings, right? But when we talk about diabetic foot, the consensus is we don't usually use alginate, honey dressing, or collagenases, right? And normally we use, normal saline. Sometimes we add acetic acid 1%, but normal saline is good enough to clean the wound with even a simple gauze dressing, right? And that's important. When you talk about dry wounds, sometimes we use a hydrogel, right? If there is minimal or moderate exudate, hydrogel. There are different types of dressings that we can use. For moderate or high exudate, we use hydrofiber dressings and hydrocolloid dressings. Now, hydrofiber dressings can absorb much more than a hydrocolloid dressing. So if it's very high exudate wounds, right? Wound protection. So this is just to highlight, when you look at the different types of dressings, you have occlusive dressings and semi-occlusive dressings. Occlusive dressings is where it completely acts like a thermal barrier, right? And it doesn't allow any anything to get in or leave, right? So that's usually mainly used in the initial stages. It's not conducive in the later stages. So what I want you all to understand from this is sometimes as the wound progresses, we need to change the dressing types we use. You can't use one dressing for the entire healing period, right? Because if you use an occlusive dressing from day one till the wound is not going to heal, right? Especially as the wound gets dry. Okay, wound care and ulcer tips. Always remember, sometimes certain dressings, when we remove it, it can be quite painful for the patient. So we need to always soak it with normal saline prior to removal. And you advise the patient to keep the affected limb elevated as much as possible. Avoid wetting the dressing, right? So if it's just a one-off thing, we can tell them a simple thing like, using a bag shown in this picture here, and gently, not tying too tight, but a small thing, you don't want to restrict the blood flow, is good enough. So for some people who have recurrent wounds or taking a longer period, and if they can afford it, there are also special systems, waterproofing systems, that will enable the dressing to be dry, right? Okay, so use of oral antibiotics. This is something I want to share with you all. Please, use oral antibiotics appropriately. We see so many patients, sometimes, they feel that if the wound is not, if the wound is not infected, don't prescribe oral antibiotics. And when you talk about infection, if there are symptoms or signs of systemic infection, so if the patient has fever, if the patient has chills, or if there's any cellulitis or redness or high CRP, then that's fine. But some people, we do see it's a neuropathic ulcer, there's no signs of infection, yet they feel that they need to prophylactically cover them with antibiotics. That is bad, right? And always obtain a history of any recent antibiotic use, and also prescribe the proper dose of the course. So we see so many patients on suboptimal antibiotic doses, right? For 3 days, antibiotics are given, right? Now, there are some patients that require antibiotics for prolonged periods of time, say 2 weeks or so. Then we always consider a probiotic as well, right? In order to maintain the healthy gut bacteria, right? That is important. Now, if a wound, always beware of a chronic or a non-healing ulcer, right? And this is, of course, first thing we need to rule out is peripheral vascular disease. The other thing is osteomyelitis, right? So if you are struggling with a wound for more than 4 weeks, there is no progression whatsoever, always then investigate, do a full blood count, ESR, and an X-ray. Why I say ESR is it's cheaper than your CRP and it's more sensitive. So if osteomyelitis and all generally have if the ESR is north of 50 or 60, then there's a high indication it could be osteomyelitis. And then do your X-rays as well. And then also sometimes we do a wound swab, right, and send them for culture and ABSD. Again, you need to be mindful of doing a swab culture properly. A lot of us make the mistake of just, opening the wound dressing and just superficially taking the swab. And they feel the wound shouldn't be cleaned before taking the swab. And that's actually wrong, right? Before you take the swab, you need to properly clean the wound with normal saline and then go right at the center and take the swab, because otherwise you're going to get contaminants, right? And sometimes we even take a small sample of tissue, right, if required. Okay, so diabetic foot ulcers, going back to our initial slide. So we've talked about prevention, debridement, offloading is extremely important, especially when it comes to neuropathic ulcers, right? Is very, very important. So that's a key factor. And there are different categories of offloading: casting, bracing, footwear, walking aids. Some of us, they use very bulky dressings also to offload, right? So the most important, what I wanted to highlight here is choose a mechanism and option that your patient can afford. That is, we have to always consider that, right? So this is in terms of diabetic footwear. So you can see there are now a lot of them are made from microcellular polymer or microcellular rubber. And when choosing a footwear, they have to be light. You have to have some form of back support, and the inside, the area should be very smooth, soft, right? And this is very important, and not very heavy. This is a picture that I took of a footwear that was available, just to highlight to you all that you can see when we were talking about offloading neuropathic ulcers and things like that. This is the second. So you have 2 layers. One, it's attached by a Velcro strap. So you can actually, cut this. Say you have a ulcer in the plantar aspect, you can make a a circle type of cut here and offload that particular ulcer, right? And then this is just a well-cooked strap, and then when it heals, you can paste it back again, right? This is one way of doing it. The other way is, I remember Dr. Hazari used to say what he used to do for his patients. He used to use 2 rubber slippers, and I'm sure other GPs also have advised their patients similarly, two rubber slippers, and they paste it together, cut the straps of one and paste it together, and then you can offload it using on the first layer as well. So that's the beauty of being a GP is providing cost-effective solutions to your patients. Sometimes we do 3D foot scanning, static and dynamic scanning, if we feel that there are certain deformities, and then they can get a customized sole done, right? So what are the resources? Just wanted to highlight. So, sometimes if you feel that, you need to send your patients for further assessments and things, there are many government diabetic clinics conducted at a general hospital. There are private sector diabetic clinics and wound care centers. There's the National Diabetic Center, which is an NGO providing subsidized care, including testing for diabetic patients. And I just wanted to acknowledge the work done by Nirogi Lanka and Suadivya. Nirogi Lanka is, I'm sure most of us are aware, Nirogi Lanka is a non-profit, I think, a project that was started by the Ministry of Health, SLMA, and funded by the World Diabetic Federation. They did an amazing job with training medical officers, nurses, how to, especially for foot care, footwear advice, how to conduct all these, clinics. And even Suvadivya, they do a lot of diabetic education and footwear, as well as education for diabetes in a whole. So there are a lot of resources that are available for us, all right? So take home points, just to summarize, right? A few things. Inspect the feet of every diabetic patient, right? Even if you do not manage their diabetes. So as a GP or a family physician, they may come to you for a flu or something else. Their diabetes could be managed by another person, right? But use this opportunity to inspect their feet. And in fact, about 2 weeks ago, a 85-year-old lady came to see me for something with regard in her arm. And then I looked at her feet and we noticed a small cut in infected toenail, right? Because she had then they cut the toenail in the wrong way. So use these opportunistic, be opportunistic in that sense. Do a diabetic foot screening, even a basic foot screening. You don't need all these fancy equipment. Just do a basic foot screening for all your diabetic patients, right? Advise them on the proper foot care and footwear, right? Always remember, if you see a callosity, you need to act on it, right? Remember active Charcots. That's the case scenario today as a differential in a patient with long-standing peripheral neuropathy presenting with acute foot swelling, right? Because by you having that at the back of your mind, you can potentially save that person from an amputation, right? Know when to refer and whom to refer, and always remember to provide cost-effective solutions. That's the beauty of being a GP is you have to understand the patient, their background, their financial situation, and be able to come up with a cost-effective solution for them. All right. These are my references. Thank you. I'll be happy to take any questions.
Thank you, Dr. Sabith. That was very, very informative and a very useful presentation. So yeah, anyone has any questions, please go ahead. So maybe I can ask you a question as well, Sabith.
Sure.
You
Yes.
mentioned with the differential for that patient, right, with the acute Charcot.
Yes.
So what actually suddenly triggers this for them to have this acute event? I mean, if it's just due to degeneration.
Yeah, so absolutely. So that's a very good question. There could be absolutely no triggering event or major event that they could trigger. They could just present. So a lot of them tend to have peripheral neuropathy for a long time, and over a period of time you get those changes like what we mentioned, the subluxation, and then you get these microfractures, and there is no one single event so it's more of a collection of events over a period of time, and then they produce and they present with an acute. So a lot of the time they may not even have redness or anything. It just could be a foot swelling, and generally it's very acute. So they'll tell you for a couple of days, right? And another way of what we sometimes we can do is in an acute Charcot, if you're not sure whether this is an acute Charcot or cellulitis, if you elevate the foot for a while, maybe a few minutes, and keep it, if it's actually an acute Charcot that had the redness should subside to a certain degree, right? But when it is cellulitis, it won't. Right, so there is no acute event, so that's why you need to be a bit mindful in terms of, and keep it at the back of your mind. I hope that answered your question.
Yes, yes. Thank you very much. I think there's a question on the thread. Are there any physical courses that we can participate to learn on foot ulcer management to improve practical knowledge? I don't know if there's something you'd know.
Yes, I think there are. So, for example, there are. I think the university in Colombo, I think Professor Rizni Qasim and they were conducting a foot course. We know that there are the primary care diabetic group conducts a diabetic course where they have a foot module as a component to it. So there are a lot, and now, like I mentioned, even things like Nirogi, Sri Lanka, and all, there are active sessions in terms of educating medical officers. There were different phases. So these are generally the resources. There are a lot of online courses as well that are available specific to the foot.
Are there any other questions at all for Dr. Sabith? I think you've given us lots of information, so everyone's quite happy.
Okay, excellent. Thank you.
So in that case, thank you. Thank you very much, Dr. Sabith. And thank you everyone for joining as well.
Oh, sorry,
and
just one
we look
thing.
forward to...
I just wanted, I think Dr. Gobinath had mentioned the thing that they were having a session. I think the CGPSL is also trying to organize a session soon. So in terms of these diabetic foot and